We are going to kick off our first rapid fire talk of the session. Dr. Bjoern Suckow from Dartmouth is going to be presenting to us on patients with chronic limb-threatening ischemia prioritize mobility over pain, support systems, wounds, or mental health.
Thank you to the Society for allowing us to present our work. In the spirit of the Life VESS meeting, I've dressed in my ski attire. This work was funded by multiple educational grants. Our previous work involved 4 focus groups of 26 CLI patients who discussed what domains determine their health-related quality of life. It showed that CLI-related quality of life was determined by mobility, pain, active tissue loss, mental health, and support systems. Our objective now was to determine in what rank order CLI patients prefer these quality of life domains, or in other words, if patients can't have every quality of life domain addressed in their care, which one matters more to them. To do so, we identified 100 patients with active CLI and randomized them to one of 2 validated ranking methods, so as to avoid bias introduced by the ranking method itself. Patients were financially incentivized. We collected demographics, medical history, info on support systems and assist devices, and had patients complete validated depression screening and quality of life surveys. The first randomized method of domain ranking presented patients with 5 cards, each naming and describing a domain, and asked that patients sort these cards in order from most to least important. The second method presented patients with a sheet of paper listing the domains, and asked patients to place numbers next to them in order of most to least important. There were no differences in patient characteristics between the 2 ranking methods. Patients were about 68 years old, 2/3 male, predominantly white, and had a breadth of educational background. 54% were married. The majority of patients were in need of a walker, cane, or wheelchair at time of enrollment, and 72% required support with ADLs. BMI was representative of the general American population. Comorbidities were representative of typical CLI patients. We had an even split between clinical Wi-Fi stages. Mean ABIs were 0.7 and toe pressures averaged in the 30s. About half of patients had an amputation. 20% of patients underwent amputation at the encounter during which they were enrolled in the study. This graph shows the mean rank placement for the domains. Lower numbers indicate higher rank, i.e. more important to the patient. On average, mobility was ranked highest. Pain, support systems, and wounds have a comparable mean rank in the middle of the pack, while mental health has the lowest mean rank. This table shows how frequently each domain was placed at each rank. Mobility was ranked first or second 75% of the time. Mental health was ranked fourth or last 68% of the time. This column is a sum of all rank positions per domain, where a lower number indicates higher overall rank. Indeed, the most frequent rank order we found among all patients was mobility first, followed by support systems, wounds, pain, and lastly mental health. We compared patients who ranked mobility first versus those who did not. There was no difference in quality of life surveys between the 2. However, patients who ranked mobility first had a significantly lower score on the depression screening survey, meaning were less depressed. We did not find significant differences in comorbidities, amputation level or timing, hemodynamic measures, Wi-Fi score, need for assist devices, or support systems between those who ranked mobility first versus those who did not. In conclusion, CLI patients value mobility over support systems, ischemic wounds, pain, and least value mental health in their quality of life. Clinical patient variables and existing quality of life measures are not associated with rank order, and therefore unable to elicit the patient preference of these domains in their healthcare. This highlights the need for disease-specific patient-reported outcome measures in CLI. Thank you very much.
Thank you for this interesting work. I guess the first question I'd have for you is, are these the results that you expected? Because they seem a little bit unexpected to me.
No, that's a great question. I mean, going into this, we had a sense that mobility and pain management were pretty much paramount. And we went into this realizing that those are at a paradox, right? The easiest way to treat pain is to remove the dead or painful leg. And that's also the main way to limit somebody's mobility. And so we went into this really trying to elicit whether there was a fair trade-off between those 2, or if one always came up on top of the other. I was a little surprised that mobility came out, but in retrospect, it makes sense. Most people are ingrained to want to keep their limb. And I think that's really what this domain of mobility is representative of. I need to keep my limb.
Interesting. There's been a lot of more work recently about, the importance of depression screening and recognizing mental health in the care of our patients and in vascular patients specifically, and even some data suggesting that depression correlates with outcomes. How do you sort of reconcile that with the fact that the patients seem to care less about depression?
I think I need to highlight here the overall depression screening scores were pretty high, meaning there was a fair prevalence of depression across the board, but it was significantly less in those who favored mobility as their main quality of life domain. And I don't know if that's a chicken and egg phenomenon or not, meaning if you're less depressed, you're more likely to want to get up and move, or whether those who are able to get around and move are thus less depressed as a result of their mobility.
Interesting. Dave Kavar has a question in the chat. Great work, Bjoern. How do you account for the relationship between these domains?
Thanks, Dave. Appreciate the question. Ultimately, I think it really comes down to the period of encounter. Most of our prior work was done in retrospect with people who had been through the treatment process, meaning we've done qualitative reviews, focus groups, and individual interviews with people who had lost their leg or gone through CLI treatment and kept their leg. Now we're focusing on people at the moment of active treatment, meaning they're hospitalized for the gangrenous forefoot, the ischemic wrist pain, and at that point are facing an amputation or revascularization and wound treatment. And so I think that is really what's driving the relationship that we're seeing here. They are in the hospital, they're kind of deer in the headlights, overtaken by the amount of work it takes, and realizing, I think for the first time, I may lose my leg. So in other words, what I'm saying is I think the relationship we're seeing with mobility being paramount is that we're doing a poor job educating these people earlier on in their PAD treatment course that they may ultimately lose their leg if they don't take care of themselves. And it's often at the encounter when they're faced with really losing it that becomes their most important realization. So if there's any take-home message here on my end is be a little bit more upfront in the fact that when I'm doing a bypass, there is a statistical chance you may lose your leg down the road, rather than we're going into this to save your leg.
Yeah, that's a great point. Perhaps just the phrasing of that term, because what you said really means the same thing, but it's the way that you phrase it. Patients aren't possibly hearing it. Another question from the chat from Chris Du. Great job. Were patients who ranked mobility first active prior to their clinical presentation?
Hey, Chris, it's good to hear from you, and I hope you're doing well in Michigan. Thanks for your question. It's a good question. And if we look at our demographic breakdown, at least half of these patients were requiring some sort of mobility assist device. I think that indicates the fact that they are in an acute setting, either hospitalized or coming into clinic unable to move due to pain or open wounds. And again, I think that highlights why mobility is such an important domain to them. It's a newfound limit in their life, and they're facing a loss of independence because of it.
And one more question from Kelly Kempe. So now that you know mobility is first, should we be encouraging more active work with PT and rehab?
That's a great question, and something that I think is varied across the board. I totally agree that we should encourage a multidisciplinary approach to CLTI treatment, especially in the acute setting. By that I mean getting not just PT and rehab involved, but prosthetists, or rehab physicians who are focused on working with people post-amputation, just to help these folks understand that there is life after amputation. I think we often go into this treatment thinking that amputation is the loss or the end game, the worst outcome. Frankly, I think there's a good subset of people who are going to benefit from an earlier amputation, and we need to be able to not sell it, but present amputation as a viable treatment option rather than a failure of all other treatment options.
Great point. I had a little bit more of a methods question. You described in the beginning of the talk that you presented these choices to patients using a card sorting method or a classic sorting method. Any difference in the outcomes there based on the method in which they were ranking these?
That's a great question. There was absolutely no difference in our sub-analysis between the two cohorts. We found no difference in the overall ranking.
Great. Well, great work. I think that sort of very enlightening and, like I said, a little bit unexpected. So thank you for sharing that.
Thank you.